Well, we're running late, and I apologize for everyone. We're really going to try to stay on course this. So every talk is 4 minutes long and 2 minutes for discussion. And in 4 minutes, I'm going to stop you. We are going to have a timer on, but we're trying to keep on, and I'm sure everybody who wants to go out tonight in this beautiful city will appreciate that. But I'd like to welcome you on behalf of my co-moderators to this, I think, a very interesting session on atrial fibrillation. And I'll introduce the first talk. It's from the very productive group in Poland, led by Peter Sawalski, and it's midterm survival after concomitant surgical ablation versus a second arterial conduit in CABG patients with AFib. Okay, and if we could have the slides. I promise I won't start the timer until the slides.
Okay, great. Thank you for the opportunity to present. As mentioned, I'm part of the Pro-Sawalski group in Warsaw, and so without further ado, for quite some time we've been studying the registry data that we have about AFib patients in different clinical scenarios. We started with investigating the effects of adding surgical ablation for AFib to coronary artery bypass grafting, showing there indeed is survival benefit associated with ablation, which has been also shown in parallel trials in here in the US. Later on, we moved to more detailed scenarios. We investigated whether patients with AFib benefit from multiple arterial grafting in comparison to single arterial grafting. And indeed, we also showed a survival benefit. And this time, we asked ourselves a question, what's the relative benefit between adding another arterial graft to LIMA or to ablate or to performing a surgical ablation? So the registry has been already introduced a couple of times. We excluded patients operating in an emergency setting and included patients who underwent isolated multivessel CABG with LIMA and divided into two groups. LIMA with one or more vein grafts and LIMA with surgical ablation, and LIMA without surgical ablation, however, with one or more additional arterial grafts. So after exclusion, we had over 3,000 patients. We did propensity score matching 1 to 2, and we obtained a cohort of 900 patients, and follow-up was 4.6 years. So patients in the ablation group, understandably, more often had their layout clipped, and they were more often performed on pump. Other than that, there were no important perioperative differences in those two groups. And perioperative outcomes were also similar. There were higher operation for bleeding in the surgical ablation group, but it doesn't translate into 48 or 30-day mortality, which is similar between the groups. In the follow-up that we had available, surgical ablation was associated with a little over 20% benefit survival compared to no surgical ablation with a second arterial graft. When we dig deeper into the data, although there is no interaction here in the subgroup analysis, however, a picture emerges. When we look at patients, we call them coronary arteries is dominant phenomenon. Patients with free vessel disease, patients with previous myocardial infarction, you can see that the benefit is almost is lower or almost non-existent. However, when you look at more AFib dominant pattern, patients with low ejection fraction and with higher Euroscore, you can see that those are the patients that benefit more from the surgical ablation. And the graph that I really like is the one on the left side. You can see the gradient of survival benefit when you go higher with Schatz-Watz score. Actually, patients with higher Schatz-Watz had the most survival benefit, which is something that we really like this result. So the limitations obviously are plenty, retrospective, observational, and it's not possible to have definite causal relationship. We have very limited granularity of AF-related data. We don't know AF type, AF duration, AF size, so all limits are conclusions. We do not have data on post-operative rich status. The surgical ablation only influences survival if it is successful. Other than that, it does not. And the lack of other endpoint and mortality is also an issue. Lastly, I just want to share a quick thought. As I believe the patient with coronary artery disease and AF treatment, while we do all minimal invasive thoracoscopy, it's praised and it's way to go. However, we must remember that CABG is the most robust treatment, and especially with patients with AFib, I believe that they should be tilted towards CABG because it actually deals with all their problems, and that's the way to go. Thank you. That's all.
You were awesome. That was very good. And yeah, very quick.
I tried to be quick.
Your English is fantastic. This very interesting abstract is open for discussion. I guess it's not an either or, but it does emphasize the importance of surgical ablation.
Yeah, if I had more time, I would also emphasize that by no means it is the work that has to discourage multiple arterial grafting. We all believe that arterial grafts have greater patency than veins, and still. However, surgical ablation may be the biggest thing we can change during the CABG surgery.
Could you comment a little bit about what surgical ablation strategy you had in these patients?
Yeah, so this is national registry data. Those are not all patients or patients from the whole mandatory registry. Fortunately, we do not have data on AF ablation type, but I presume it's mostly epicardial biclamp radiofrequency ablation because that's the way we generally do it in Poland.
And the appendage clip strategy was it all clipped, or could it be any?
It's mostly with atri clip for over 10 years now. We mostly use devices to clip the appendage. Yeah.
Any other questions? Okay. Do you want to introduce the next?
Thank you.
So next title is Impact of interdisciplinary screening protocol on atrial fibrillation ablation during concomitant cardiac surgery. Presenter is Sander Jacquemain.
Hello everyone, thank you for joining this session, all of you who are here. I'm Xander, I'm a postdoctoral associate at the University of Pittsburgh Medical Center, and I'll be presenting our work on interdisciplinary screening protocol on atrial fibrillation ablation during concomitant cardiac surgery. And really this work is mostly done by the APPs and the other interdisciplinary staff. I'm just a research fellow who created this statistical plan, but all of this is on them. So as you all know, atrial fibrillation is a progressive systemic disease with stroke, heart failure, and mortality, and guidelines recommend surgical ablation during cardiac surgery. However, there is a persistent undertreatment due to underdiagnosis and low awareness. You may question why. To read AF, I said randomized controlled trials demonstrate benefit, atrial fibrillation is common. The economic burden of atrial fibrillation is predicted to increase to over 175 billion by 2050 in the US, which is incredible. But there's a major gap in care. Without preoperative diagnoses, the odds of ablation are incredibly low. If we looked at 2014 Medicare data, you see that if patients weren't being detected with AF, the ablation decreased by 50%, the odds of ablation. So detection is the critical first step to delivering life-saving therapy. As you see, the clinical practice guidelines that were presented as well in STS are on the bottom right, and they show that over time, ablation and left atrial appendage occlusion has been increasing, which is good. However, in a sample of our population at UPMC, we saw that we had quite a large rate of missing patients. We had 46 patients in a random sample we took in 2024 who actually only got a missed opportunity for partial treatment, which is either surgical ablation or clipping. 28% got partial treatment, and only 26% got guideline recommended treatment. This is due to multiple options, potentially not seeing it in the plan or detecting AFib on time. So we implemented an interdisciplinary atrial fibrillation screening protocol in 2025, which included APP education, patient questionnaires, AHR reviews, and the atrial fibrillation decision algorithm. This is presented on the right hand. You can see the questions that the APPs would ask the patient if they've taken blood thinners, do they see a heart specialist, all the kind of questions you would relate to our atrial fibrillation. And then they also performed the EPIC search prior to the operation and looked for any atrial fibrillation that was documented in the past. And in any patients where this returned yes, so any patient that would have atrial fibrillation, we decided either, okay, this is a class 1 recommendation for ablation or clipping, or patients who were deemed at risk, we decided to give them a short-term monitoring device to see if we could detect AFib prior to the surgical procedure. Then we performed a retrospective review of all the cardiac surgeries in the past, so historical cohort from 2024 to from 20 to 2024, and then after this implementation, and we did some analysis on the trends. And we performed 5,198 cardiac surgeries within that time frame. And prior to the implementation, our annual ablation rates were low, around 2 to 6%. They were increasing slightly. However, after implementation, we can see that there's a major increase with the red curve on the right and the histogram being the projected year to date, which is a 1.61 odds ratio of increase over the annual increase that we were observing from 2020 to 2024, which was 22%. When we adjusted for baseline characteristics, such as age, sex, or baseline comorbidity status, we also saw that the risk increased by 4% of getting an ablation. So we saw that we were actually treating more patients than before. So in conclusion, a focused education and standardized screening protocol improves AF identification, and a coordinated team workflow increases in ablation rates. And this is clinically important for practice. Thank you all. I'll take any questions.
Anybody with questions regarding this very interesting protocol? And I think it's a great idea, and congratulations. I'm interested because you asked some very, non-specific questions, which may not, like most patients, if you ask if you felt irregular beats, your heart skipped, almost all, a good proportion would say yes. What did you do once they answered yes to that? How did you document that they actually had AFib?
So that's where the combined approach came in. So we ask those questions, then those patients are deemed at risk. We look in the charts if, like, at any point in time during their entire medical history, it said any mention of any atrial fibrillation that was detected. Or if, for example, if they had an Apple Watch that said, oh, you have AFib, those kind of things were documented. And then it was decided based on an individual patient, of course, if we had enough evidence or if we needed this short-term monitoring device prior to the surgery, which is something we give quite frequently.
Yeah, I would caution that a lot of the EPIC, when you go into your electronic medical record, even the diagnosis of AFib, you can't find any documentation.
Yeah.
So I would confirm, even a mention of it with some type of prolonged Holter monitoring pre-op if you could. Yes, Armin.
Xander, that was a great presentation. Do you have a sense of your conversion from diagnosis to treatment? So it's one thing to pick up on diagnoses, it's another thing to convince surgeons to actually perform the procedure. Do you have any sense of that at all, what that conversion rate is like?
So we do not have that conversion rate yet because we have multiple surgeons and it's quite hard to get that data. This analysis was only based on the ablation rates, so it's quite biased in the fact that we may even be having more missed opportunities that we don't account for in this analysis. But we did see for 2024 to 2025, for example, a threefold increase in ablation rates in general across the hospital at our main campus, and I think a twofold increase in clipping. So I assume that since the APPs are hospital-wide, not surgeon-dependent, that it's a general effect.
Great. Thank you very much.
Thank you.
Thank you very much. Thank you very much. Thank you very much. We move on to the next speaker. Okay, next speaker is Dr. Amiran Levsky from Moscow, Russia. The title is the outcome of the PURBA RCT on comparing the preventive strategy for the new onset preoperative AFib in cabbage. Please go ahead, please.
Dear colleagues, dear chairman, I have no disclosures. Postoperative atrial fibrillation still remains a relevant problem in coronary surgery. There are two main prevention strategies of POF: pharmacological and surgical option. Amiodarone administration decreases of POF incidence, but not quite effective. Some study in surgical prevention strategy concluded that PVI does not decrease the incidence of POF and adverse effect. That is why we have designed a RCT trial follow-up to evaluate of influence PVI of prophylaxis of new onset POF after cabbage. Patients were randomly allocated into 4 groups. First group is only conventional cabbage. Second is conventional cabbage plus PVI. Third, cabbage plus PVI plus postoperative amiodarone administration. Fourth, cabbage plus postoperative amiodarone administration. To date, we have assessed outcomes in 174 patients. The baseline clinical characteristics of a patient in all groups were similar in such parameters like age, gender, angina class, and others. Here some echo data, there were no significant differences. We are using the bipolar PVI before aortic cross-clamping. Study groups were not different with respect to intraoperative results, including operation time, CPB time, number of revascularization requiring arteries as well. There were no statistically significant differences in adverse effect in all groups. No MACE primary endpoint were registered in this study. The POF incidence was significantly different. So the incidence of POF in PVI amiodarone group was lower than in amiodarone group. The incidence of POF in PVI group was lower than in cabbage-only group and in amiodarone group. The incidence PVI amiodarone group also showed significant lower time of ventilation as well as ICU length of stay. Up to 36 months, freedom from MACE in PVI amiodarone group and PVI group was similar. In cabbage-only group was lower. However, no statistical significant differences were found. Freedom from AF was significantly high in PVI amiodarone and PVI group. So, in conclude, the combination of prophylactic PVI and amiodarone administration revealed significant positive results in the prevention of new onset postoperative AFib. Thank you for your attention.
Thank you very much. It's a very important study, and you said that the combination of the PVI and amiodarone reduced the postoperative AF. Any questions from the floor? Yes, please.
A very interesting study. Maybe I've missed the information. Was the cabbage performed in the 4 groups performed in the same way, or there were differences?
Yes, the same way, absolutely the same way. And we divide into 4, randomly divide into 4 groups.
Perfect. Thank you.
Why the combination with the amiodarone is better than only PVI? So even the amiodarone
most proof evidence we obtained in the group PVI plus amiodarone. But amiodarone only, it's not good evidence and statistically insignificant.
Only amiodarone doesn't mean that the combination is very important.
Yes,
you said.
Thank you.
So how long did you dose amiodarone?
600 milligram per.
How long?
How long?
Yeah,
We use after post-operative period in 1 month.
1 month.
Yes.
Thank you.
Okay. Thank you very much.
Thank you, that's excellent.
Next presentation, my.
Oh, you've got the next one too.
Sorry.
Fantastic. Okay. So the next presentation, also by this group, is simultaneous Maze 5 procedure in patients with concomitant AFib and coronary bypass grafting. Aaron?
So I have no conflict of interest. Ischemia, one of the most important trigger of AF, and the incidence of concomitant AF in patients requiring CABG is approximately up to 10%. Concomitant AF portends poor outcomes after CABG, and it associates with postoperative mortality and morbidity. Some of latest guidelines strongly recommended concomitant surgical ablation of AF with CABG. But even though the proportion of concomitant ablation CABG is smallest, cause of stagnation in here, today the Maze 4 procedure is considered the best treatment option for open heart surgery. But the use of this procedure in CABG requires opening the heart. So that is why we have been introducing the procedure proposed by Dr. Rivishvili on pump beating heart controlled restoring of exist block and sinus rhythm. Left atrium lesion set is done using a bipolar clamp passed through per string. Right lesion set is performed on an open atrium. We form 5 ablation lines and do an ablation of isthmus. The results of this procedure were followed up to 36 months in 105 patients, 32 with paroxysmal and 33 with non-paroxysmal AF. No statistical differences in baseline characteristic we obtained. The left atrial size was significantly larger in the non-paroxysmal group. Accordingly, the rates of AF presence at the time of admission and the duration of AF is the non-paroxysmal AF group was higher. Study groups were not different with respect to intraoperative results. The recurrence rates of AF was statistically significantly high in the non-paroxysmal AF group. The complication rate did not exceed the reference values for isolated CABG. Freedom from MACE during 36-month follow-up in the paroxysmal group was high compared to non-paroxysmal. Freedom from AF atrial during follow-up was also expected to be high in the paroxysmal group. To conclude, the results of concomitant Cox-Maze 4-5 procedure allow us to recommend this procedure for simultaneous AF treatment in CABG. Thank you for your attention.
This very interesting paper is open for discussion. I may start out. I think it's an interesting strategy, and I know you had to go very quick, but could you explain how, on the left atrial side, do you do a left atrial isthmus lesion? And if so,
It's a problem. I agree with you. But now we investigated external line with cold.
cryo.
Yes.
And on the right side, so you don't do an isthmus line, but you've got
Not
good-
now.
not now.
No.
And on the right side, how do you get down to the tricuspid annulus with the bipolar clamp alone, or do you use cryo in that situation also?
Maybe you are right. Because sometimes it's too thick for radiofrequency ablation bipolar. Maybe two. Mitral line and isthmus line. Mitral isthmus and tricuspid isthmus. Maybe you are right. We will investigate. We will assess it.
Yeah, it'll be interesting to see how you continue to follow.
Cryo is good option for this procedure.
Yeah, I would think it would be a very good in this situation. It'll be interesting to see late what the incidence of flutter is. Oh, sorry. Sorry. Okay. No, you did great. Thank you for keeping on time.
Okay, so next title is early and long-term results of radiofrequency pulmonary vein ablation for various forms of atrial fibrillation during isolated cavity. So presenter is Mikhail Sventosky.
Dear colleagues, we did cite our report to the topic early and long-term result of radiofrequency pulmonary vein ablation for various form atrial fibrillation during isolated cavity. Atrial fibrillation is a common conjunction as a cardiac surgery patient and is prevalent in patient undergoing coronary artery bypass surgery. Dispute is surgical ablation for atrial fibrillation during cavity is performed less frequently than during valve procedure. The lower use in surgical ablation in cavity is primarily because the left atrium not opened, which is necessary for perform the most efficacy the surgical ablation technique, the Cox-Maze procedure. However, numerous studies have shown that surgical ablation during cavity is associated with superior perioperative and long-term outcomes, including reduced mortality and stroke rate. The prevalence of concomitant atrial fibrillation undergoing coronary artery bypass grafting range from 10 to 20%. This number will likely be necessary due to an again population with increased coronary artery disease and other comorbidities. Current rates of concomitant surgical ablation is patients with perioperative atrial fibrillation who are undergoing coronary artery bypass grafting range between 17 and 34 Bespeed cabbage beginners most frequently performed operation. Dispute this slide cabbage has the lowest rate of atrial fibrillation, leaving a significant population of the patient with untreated atrial fibrillation. This slide dispute rates of surgical ablation by type of cardiac surgery performed, published in the Less Society of Thoracic Surgeon 2024 Clinical Practice Guidelines. Radiofrequency ablation, radiofrequency isolation of the pulmonary vein was performed immediately after the start of artificial blood circulation on the beathead. First on the right, then on the left, using a bipolar electrode with at least 8 application with mandatory change in the configuration of the application line and until control achievement of transmurality. The purpose of our research was to evaluate early and long-term results of radiofrequency pulmonary vein ablation for paroxysmal and persistent atrial fibrillation during isolated coronary artery bypass grafting. This study was conducted from 2011 to 2023. The indication for surgery in outpatient was coronary artery head disease. Radiofrequency ablation was performed on 42 patients with paroxysmal and 31 patients with persistent atrial fibrillation. The mean age of the patient was 63.5 years, ranging from 52 to 78. The EVO 48 men and 23 women. More detailed information is performed in the table. In all case, ablation was performed using ATQ bipolar radiofrequency electrode with the head beating a normothermic temperature. 2 lines of the 8 applications were performed. All patients underwent isolated aortocoronary bypass surgery. The mean number of grafts 2.8, ranging from 1 to 4. Action with the left atrial appendage, 61 patients received the ligation of the left atrial appendage, 6 patients Ovation, 5 patients did not any manipulation of the left atrial appendage. Due to anatomical particularities, this patient had a small left atrial appendage. Our results. No pacemaker implantation was required. During follow-up, 16 patients were examined. The mean follow-up period was 6 to 73 months. All patients were lived. The freedom from stroke was 100%. In the compared group 1 and 2, the freedom from atrial fibrillation requirements was 96.8 and 96
I think
after 12.
we'll have to have you summarize now. You've gone over time. So if you can just go to your conclusion slide.
Conclusion. Based on this research, we believe that single-stage simultaneous pulmonary vein ablation during coronary artery bypass grafting in efficacy and safe procedure for treatment for paroxysmal atrial fibrillation, providing a favorable hospital and long-term results. Thank you for your attention.
Excellent. Anybody would like to discuss this paper? I'll maybe start out. You know, a lot of other series have shown much worse results with just pulmonary vein isolation at the time of CABG. Why do you think your results are so much better? It is a small study, though, but of your persistent, how many of the persistents were long-standing persistent?
Persistent patients is only pulmonary vein ablation is a small procedure. This patient had the Cox-Maze procedure with CABG.
If they had long-standing persistent? I'm just wondering, of your persistent group, how many had long-standing?
Paroxysmal atrial fibrillation group, its results better, but persistent, it's 56% in 60 months after.
Okay. Armin?
Thanks for the presentation. Just a quick question. How did you decide on 8 separate ablations as opposed to 3, as opposed to 5, as opposed to 10? How did you decide on 8 different ablations on each set of veins?
Thank you for your questions. It's
I actually like it very much. I think more is typically better with pulmonary veins.
yes, sure. Yeah.
So it was actually quite nice to see that. I was just curious if kind of how you came to that number.
If you make Cox-Maze procedure, its results is better. Yes.
Thank you.
Okay, thank you very much.
Thank you. So next speaker is Dr. Massimo Baudo from Pennsylvania. The title is The Outcome of All Comers Robotic Left Atrial Appendage Occlusion.
So again, good afternoon. Thank you for staying here this long. I will be talking about all comers patients undergoing robotic left atrial appendage occlusion in our institution. These are my disclosures. So the landmark LAOS 3 randomized trials paved the way of concomitant left atrial appendage occlusion in cardiac surgery in patients undergoing cardiac surgery with AF and high CHA2DS2VASc score. It is now, by all international guidelines, a class 1 recommendation. Therefore, we thought that also minimally invasive and robotic surgical platforms can expand the exclusion of the left atrial appendage. And so we investigated in our institution the occlusion of LLA in patients also undergoing robotic CABG. Therefore, we retrospectively included all our patients undergoing robotic left atrial appendage occlusion with or without robotic CABG between June 21, December 24. So generally the indication for the surgery was AF with high CHA2DS score, if they had anticoagulant intolerance or contraindication, or they could have been referred to our center for contraindication for transcatheter procedures or a failed previous attempt. So all patients underwent preoperative CT angio and TE to exclude the presence of a thrombus. So briefly, this is done through three parts: second, fourth, and sixth mid-clavicular line. All patients underwent concomitant cryonerve ablation. The robot was then docked to the patient. A subphrenic pericardial incision was performed to expose the appendage and the relevant anatomic nearby structures. Airflow port was then inserted in the mid-axillary line as a tool of intrathoracic communication. The left lateral appendage was then occluded, and after confirmation through TEE that the location was correct, it was completely deployed. So a total of 28 patients were included. Mean age was 73 years, mostly men, and you can see all the comorbidities on your left. In particular, focusing on AFib, 90% had atrial fibrillation, 5 patients had contraindication to oral anticoagulation, almost a third had a previous stroke. CHA2DS score was mean of 3.6, and the left atrium was not excessively dilated. Almost 80% underwent a concomitant CABG, which was performed after the left lateral appendage occlusion. Looking at the most fearful complication, stroke, bleeding, unplanned coronary intervention was not reported, including no hospital mortality. After a median follow-up of 1.4 years, was 1 death due to cancer. 12 patients discontinued oral anticoagulation, 9 continued, and 7 never had it in the first place when discharged. Regarding antiarrhythmic drugs, 7 patients still had antiarrhythmic therapy, 7 were in AF, and 2 received a permanent pacemaker. There were no cases of MI or repeat target revascularization. There was 1 single non-disabling stroke 1 year after the procedure due to a minimal residual stump. So in conclusion, endocardial therapy has proven through many different randomized trials how it can prevent stroke, but it is limited by anatomy and need of anticoagulation, which international guidelines still recommend despite of LLA occlusion. Basically, we confirm what other publications have shown. You need a high level of robotic surgical experience to perform this procedure to optimize outcomes. Thank you for your attention.
Thank you very much. But your study design is left appendage occlusion for the patient with AF. You included the 3 patients with no AF.
Yes, because we also include the patients who still received LLA occlusion for other reasons. Could have been contraindication for anticoagulation, still with high risk of stroke, or previous attempts of occlusion which could not be performed or was contraindicated due to anatomy.
Okay. And the majority patient had paroxysmal AF, not the
yes, most
yes.
patients have paroxysmal AF. Yes.
Okay. So for the future, do you think all comers, even without AF, should be done occlusion?
So I may be a little bit biased on that. I published a meta-analysis showing that there is a benefit in stroke prevention by occluding left lateral appendage independently of AF. These were still patients at high stroke risk. So this is my answer. I think it will maybe be demonstrated in future trials for high-risk, stroke-risk patients. I don't know for low-risk.
And also the procedure was done before the anastomosis?
Yes, it was the first thing done in the robotic environment, LLA and then the CABG.
Okay. Any question from the floor?
Thank you.
Thank you very much. Thank you.
Okay, and our next talk will be comparative midterm outcomes of RITA versus radial artery as a second arteriograph in patients with atrial fibrillation undergoing isolated coronary bypass grafting. Again, from group involved.
Okay, so our group comes up with more exotic ideas to compare patients with AFib. And since we have this database, we're trying to make the most use of it. So, as mentioned, here we try to investigate what's the best second arterial graft for patients with AFib. So obviously, left internal mammary artery is considered to be a golden standard. However, since we want to do arterial grafts, we need another conduits, and two most important players are radial artery, right internal mammary artery. Patients with AFib have shown to have poorer prognosis after CABG, probably related to all the AFib complications, but also maybe to there is something going on with the flow, and that's a very interesting study with Dr. Shin, I like very much. On the right-hand side, you can see that that the flow is much more diastolic dependent in arterial graft than in a venous graft, and when the patient had AF induced, you could see that the flow in the arterial graft is more diminished than flow in a vein graft. Therefore, suggesting that maybe arterial grafts are more prone to a low flow during AF than venous grafts, and a radial artery is known to be prone to a spasm with the low flow. So that's the background. The study design was typical. We included isolated CABG patients and performed propensity matching. We have very small groups, which limits our generalization and ability to conclude definite results from our study. So the final group was a low risk, 0.8, 60 years median age. In the right internal mammary group, almost 90% of the RITAs were colonized, which we're happy with. However, less than 5% of patients received any AF-directed treatment, which is just sad. The remote procedures performed on pump and more no touch in the RIMA group. In terms of perioperative outcomes, patients in the RIMA group had longer ICU stay, or there were no other differences with perioperative outcomes. In the follow-up that we had available, we were able to see a survival benefit associated with RITA grafting. However, we must press on the limitations of the study. Mostly, I know I'm shooting my own boat here, but the modest sample size probably is inadequate to assess mortality, and it's very likely that other factors in graft choice drive the difference in survival. If the difference exists in survival between arterial grafts, we probably need much more patients to get a clean result. And other limitations inherent to the register study has already been mentioned, so I won't go follow up on that. Thank you.
And this paper is open for discussion. Excellent job presenting that in a very concise way. Could you explain? It seems like very few patients in either cohort had AFib ablation.
Yeah, that's
is that strategy still in force at your institution, or you're more aggressive? And how did you manage the appendage in those groups?
Mm-hmm. So when I said less than 5% of AF treatment, I mean any AF treatment. So LA ablation, LA occlusion, or surgical ablation. And when most of it is still LA occlusion. It's difficult for me to answer. It's still this is national data. It's not my center data. My center is very AFib oriented. Almost no patient in our center leaves operating table without at least LA occluded. And if we don't do ablation, there must be huge atrium, very long standing, and even then, our boss says it's not happy with it. So So in terms of national data, for many years there was problem with reimbursement in Poland. Basically, the cost of AF treatment and cost of LAO devices the hospital had to eat because there was no reimbursement, only in mitral surgery. Since 3 years, we actually have AF treatment reimbursed during CABG, but it didn't really overlap with the population in the study.
Yeah, but hopefully urge you that your other sites to adopt a more aggressive strategy, because we've certainly shown that surgical ablation improves survival even more than having a mammary graft in patients with coronary disease. So it's a big missed opportunity in those patients.
Thank you.
Thank you.
Okay, so next title is it possible to use an isolated epicardial radiofrequency ablation of the pulmonary vein in non-mitral cardiac surgery? And the presenter is Dr. Amiran Levishvili.
Dear colleagues, we decided our report to the topic. It is possible to use isolated epicardial radiofrequency ablation of the pulmonary veins in non-mitral valve cardiac surgery. In review by McCarthy and colleagues of the Medicaid database, a lower population of patients with concomitant atrial fibrillation undergoing coronary artery bypass grafting received ablation choice undergoing mitral valve surgery at 20.1% with versus 61.8% respectively. However, because of the large number of CABG performed, the absolute number of CABG patients with perioperative atrial fibrillation was great any other group. The need for this review system for persistent treatment of atrial fibrillation patient undergoing coronary artery bypass grafting disputes the document association between untreated atrial fibrillation and outcomes. Also, surgical ablation during CABG is proved to be safe and effective. As will be outlined, its use and the result for Congress about the added procedural risk, extended operative time, and a lack of familiarity with ablation technique among surgeons. There is also an misconception that coronary revascularization alone can mitigate the arrhythmogenic effects of atrial fibrillation, leading to recurrence to performed concomitant surgical ablation. This is already talking about surgical technique today. The purpose to the possibility of using isolated epicardial bipolar radiofrequency ablation of pulmonary vein for simultaneous treatment of concomitant atrial fibrillation during non-mitral valve cardiac surgery. A retrospective two-center study includes 115 patients with paroxysmal atrial fibrillation who on treatment combined epicardial ablation to the pulmonary veins and non-mitral surgery, coronary artery bypass grafting, or aortic valve replacement. 70% patients underwent isolated coronary artery bypass grafting, 27 patients isolated aortic valve replacement, and 3 patients on treatment combined coronary artery bypass grafting and aortic valve replacement. The average of patient was 63.1. 46 to 78 years. there were 78.2% men and 21 women. The result of bipolar radiofrequency ablation of the pulmonary vein were assayed in hospital and follow-up 60 months and 130 months. And the regression analysis was performed to the risk factors for recurrence of paroxysmal atrial fibrillation in follow-up. More detailed information in this table. By the end of the hospital stage, of recurrence of atrial fibrillation was 98.5% of patients. The complication association with radiofrequency ablation of the pulmonary vein were not noted. The average period of remove observation was from 3 to 113 months.
We're going to have you summarize pretty quickly because you're out of time. But here we go. Good.
Freedom from MACE at the follow-up 16 and 130 months were 96.6 and 92.6%. Concludes bipolar radiofrequency ablation of the pulmonary vein in the non-mitral disease group can be performed in patients with a low risk of atrial fibrillation recurrence in the long term within left atrium area of less than 23 square centimeters. Thank you.
Thank you. Thank you so much. Could just, since you're just doing pulmonary vein isolation, did you confirm exit block in all these patients or any objective test on how efficacious the PVI was?
We recommended make pulmonary vein ablation is patient with paroxysmal atrial fibrillation in going open heart surgery.
So, yeah, the one thing we found with the bipolar clamps is the number of ablations isn't that important, but to do double ablations without unclamping was. The other thing is all the lesions, when we looked at human hearts that were turned down for transplant, all the lesions are transmural if your conductance gets above 15. But if you have really low conductance, you could do like 100 ablations, it's not going to work. But if you do a double ablation, then it works by conductive as opposed to resistive heating, and it does seem to work. But did you do double ablations without unclamping, or did you always unclamp?
Of course, it's the double clamping. Okay. It's yes.
Any other questions? Well, congratulations on excellent results.
So next title is Novel Hybrid Approach, Unilateral Left Thoracotomy Maze Ablation and LA Occlusion, combined with robotic Lima LED bypass. Presenter is Mariusz Kowalewski.
I will be giving a lecture on behalf of Professor Kowalewski. So here's the potential conflict of interest. And I'm delighted to present the case of a 66-year-old male patient with fast paroxysmal atrial fibrillation and severe symptoms refractory to antiarrhythmic drug treatment. The patient was initially scheduled for two-stage hybrid ablation. However, in the procedural assessment, the computed tomography angiography revealed diffuse LAD disease with high calcium score. The coronary angiography and FFR confirmed significant stenosis in the proximal LAD, and after shared decision-making, the patient was scheduled for two-stage hybrid approach with concomitant robotic midcap. In contrast to standard TTMAs, we proceeded with the unilateral left-sided thoracoscopic approach, which actually allows for complete lesion creation just like in the standard bilateral approach, while avoiding the risk of complication associated with contralateral access. Additionally, the left atrial appendage was occluded with epicardial clip. Using the same ports, robotic lima harvesting was performed and then followed by the lima lady anastomosis performed through the left anterior mini thoracotomy. The post-operative period was uneventful and the patient was referred for 3 weeks cardiac rehabilitation program. 3 months after the procedure, he underwent the second stage of the hybrid approach, which included control electrophysiological study. The EPS confirmed all pulmonary veins isolation, however, 3 bonus applications were required in the middle roof line. Additionally, the cavo-tricuspid isthmus isolation was performed to prevent typical atrial flutter. In 1 year follow-up, the patient remained stable in good general condition and maintained the sinus rhythm of antiarrhythmic drugs. On the left-hand side, you can see the favorable cosmetic outcome of this approach. So to summarize the key points of this study, the main message is that the robotic midcap can be safely and effectively performed with concomitant hybrid ablation in selected patients with isolated LAD disease and atrial fibrillation. The robotic midcap is associated with reduced surgical trauma, reduced postoperative pain, and accelerated recovery time. Moreover, the unilateral thoracoscopic access for TTMAs enables complete lesion set creation, just like the standard bilateral approach, while avoiding the risk of complication associated with contralateral access. Nevertheless, both procedures demand highly advanced skills and should be performed only in specialized centers. So thank you for your attention, and if you have any questions, I will be delighted to answer.
Great presentation. Just curious, how many of these have you guys done now?
A few. Actually, we're just starting the approach. As in our center, the standard approach is the bilateral approach, because the unilateral approach demands ideal anatomy, actually, and also if the patient is obese, it precludes, because the left-sided thoracoscopic approach uses the same left-sided clamps as in the standard technique, and if the patient is obese, we can't actually reach the right-sided pulmonary veins because the clamps are basically too short. So the patient selection is crucial, and we proceed with the bilateral approach as the gold standard. However, in selected cases, just like this one, the unilateral approach seems beneficial, as we can utilize the same approach for the robotic lima harvesting and minimize the surgical trauma.
Yeah, that's fantastic. Is there any thought in those patients who have contraindications to a unilateral approach to approach bilateral veins to leave the right veins for the hybrid portion of it?
The main limitation is that we need ideal anatomy. Also, the chest, the barrel-shaped chest is the contradiction. Also, the pulmonary disease, advanced pulmonary diseases are the contradiction, as the unilateral approach demands selective lung ventilation. And during the right-sided procedure, the left lung is deflated, and also when we clamp the right PVI, we see the significant decrease in the blood pressure and also in the oxygenation. So if the patient has advanced pulmonary disease, that would be a problem.
Thank you. That's fantastic. Last question. So just a technical question. So you use your thoracoscopic ports initially, and then you take those out and you put in your robotic ports in the exact same...
That's correct, yeah.
That's fantastic. All right, thank you so much.
Thank you.
Thank you.
So next speaker is Dr. Amiran Labishvili from Moscow. The title is Management of Left Atrial Appendage Isolation During Simultaneous MES5 Procedure and CABG.
Dear colleagues, dear chairman, LA has a specific anatomy, and the shape of LA is in the form of the chicken wings the most common variant followed by morphological variants such as cactus, windsock, and cauliflower. In fact, Dr. James Cox said, this is our most lethal human attachment. The least common and most dangerous and difficult to occlude is cauliflower left lateral appendage. Today, strong evidence has been obtained on the effectiveness of surgical LA occlusion and is associated with a low incidence of thromboembolism and all-cause mortality. Laos trial has demonstrated that LA occlusion significantly reduced the incidence of stroke. So, last recommendation, LA occlusion has been upgraded to first A. Two main surgical approaches should be distinguished: exclusion and complete removal. Today, we prefer exclusion using and stapler. We compared two methods of exclusion of LA in CABG in 123 patients, endostapler and double ligation. We used an endostapler on 72 patients and double ligation on 31. There were no statistical differences in baseline characteristic of compared group. Relatively unsuccessful closure with stump more than 10 millimeters we obtained in double ligation in 4 cases and in endostapler in 2 cases. We didn't observe any death and strokes in the group up to 36 months. 4 patients in the ligation group had perfusion in LAA. To conclude, among the surgical LA exclusion option in CABG and the stapler-assisted amputation, the most promising in terms of effectiveness. Thank you for your attention.
Thank you very much. I've never done the double ligation with the string. I've never done. How strong do you tie the on the appendage or base of the appendage?
Now we use the stapler, but we use double ligation just in the neck, on the neck, and double ligation it is strong, very strong.
Very strong.
Yes. Very strong.
Don't you have any concern about the injury of the left atrium?
And typically use bipolar ablation in this line also because it's stopped the moving of and maybe it's a reason for good occlusion. Good.
And your result recommend that recommend us use the clip rather than the ligation.
Yes, sir. Yes.
So recently you do only clipping.
We continue our trial, but we use the stapler.
Okay. Any question from the floor? Very interesting study and. Okay, thank you very much. Thank you. So, Dr. Gastova Orela is here, number 24, from the California. Nobody. So we should. So anybody else have not yet presented? It's okay. Anybody finished? So it's time to wrap up the session. Thank you very much for attending this session. Thank you very much.